Hi there, my name is Dr. J. Michael Bennett. I am an orthopedic sports medicine surgeon. I am fellowship trained in sports medicine, specializing in disorders of the shoulder, elbow, and knee. And this is the whiteboard series on education of orthopedic issues regarding the shoulder, elbow, and knee. Today we're talking a little bit more about the shoulder, and in particular we're going to talk about shoulder instability and dislocation. So I just wanted to show you basically a model here of the shoulder and what it looks like. This is the scapula, which is the shoulder blade. This is the coracoid, which is the bone that actually extension of the scapula. This basically is your scapular spine that comes out behind the scapula here. It's this bony ridge that you feel in the back of the shoulder, and it comes across into the acromion, which comes across the shoulder, and that meets the clavicle up at the front. The clavicle up at the front here. And right here, between these two bones, is the acromioclavicular joint. Okay? When we have a lot of athletes that come in that land on their shoulder, injure their shoulder, and people say that they had a shoulder dislocation, a lot of times they may be meaning the acromioclavicular joint dislocation, meaning that the ligaments here between the clavicle and the acromion have been stretched, and the clavicle gets elevated up a little bit. And we'll talk about that here today. This here is your glenoid, which is the socket of the shoulder, and then this is your humeral head. So for all intents and purposes, this is the ball and socket mechanism of the shoulder. The glenoid is a concave surface, oval shaped here, larger at the base and smaller at the top, and provides stability to the glenohumeral joint. Shoulder dislocations, when they occur, is when the ball and socket become dislocated. The ball slides out either in the front or in the back, away from the glenoid. Okay? Many times the position that this occurs in is the position of abduction and external rotation. So a lot of times we'll see patients that come in after a football injury where they've been caught out with their arm abductally externally rotated. Someone hits them from behind, someone's running at them from up front, pulls their shoulder back, their joint pops out. When it pops out, it's usually at the anterior-inferior aspect, meaning it's down here, and a lot of times it can get stuck because it actually gets locked underneath this glenoid. Okay? And you can see when this ball, if it does dislocate, this glenoid can actually punch a hole in this humeral head, and that's called a Hill-Sachs lesion. So if it punches a hole in the humeral head, sometimes it can get locked there. And oftentimes this is where a certified trainer or sports physician reduces the shoulder, pops it back into place, because that's immediately what you need to do. Okay? You don't want somebody to sit around with a dislocated shoulder for a long time. So you want to pop it back into place. Now after popping it back into place, depending on the age of the patient and the mechanism of injury, you can determine what exactly was injured during the dislocation. If it's a patient that's older than, say, age 45, that had a dislocation, more than likely they're going to be having more a bony injury or a rotator cuff tendon injury, where the tendon, the musculotendinous structures are disrupted and torn, and it no longer stabilizes the shoulder, and the shoulder was dislocated. And you can refer to our talk on rotator cuff issues if you want to get more information about rotator cuff issues. And then if they're a younger patient, such as your high school players that have a dislocation, that is more of a soft tissue labral injury, sometimes even a bony injury. So if you think of this socket almost like a golf tee, and the ball like a golf ball, and it's knocked off, and it takes a little chip of that golf tee with it. If you ever tried to put a golf ball on a golf tee that's missing part of its circumference there, it becomes unstable, so it dislocates every time you try to put a ball on it. It rolls off. Same thing with the shoulder. If it's missing a portion of its stabilizing structures around this glenoid, then it becomes unstable and recurrent dislocations occur. And over time, it can actually wear away certain portions of the bone, create arthritis and long-term problems. So let's go through some of these things that I just mentioned here. So if we're looking at a shoulder, okay, this here is this, as best I can draw it. This is your AC joint right here, the acromioclavicular joint. Clavicle meeting the acromion, which is it comes off of the scapular spine here in the back of the shoulder. So when an athlete or anybody falls on what we call an adducted shoulder, with their shoulders tucked in their side, such as a football player that has the ball tucked in the side, he lands on that shoulder and boom, hits the shoulder. What becomes injured are the ligaments that support that acromioclavicular joint complex there. So depending on the type of injury, or depending on the type of mechanism of injury, and how hard they're hit, determines what kind of outcome they're going to have. So what happens typically is you'll get a separation of the AC joint. So they say a shoulder separation. So that means that this joint widens a little bit. So you've got this right here. So this picture right here, if you have the injury, and let's just say that these ligaments are strained, but the shoulder's still reduced and it's not disrupted, then that's a grade 1 AC joint separation. Now on top of this, that I failed to mention, there are also some ligaments called the coroclavicular ligaments that come down here as well, okay, that I'm not really showing on this picture, but these come across here. That actually helps stabilize that clavicle and keeps it from popping up. On this picture here, or on this model here, you can see the clavicle coming up. This is the acromion. Again, coming back, all this thick ligamentous structures, this is all the AC joint ligaments. And these are the corococlavicular ligaments here, and they go from this coracoid structure here, which comes up off of this glenoid. I apologize for my drawing again, like right that. And they insert right there, okay? So this is what we're looking at here. So you have two of them here, two sets here. So going on to the next set here, if you have a disruption of part of these, like for instance, you have a disruption of these ligaments here, you have a little bit of a separation now, okay? This is more like a sprain. Now you got a disruption of your acromioclavicular ligaments, but these are still intact. So for the most part, you still got a decent alignment. It's not completely stretched out or elevated. And this is a type 2, and you can treat this in a sling and just modification activities and let it heal in. A lot of times people heal up fine with this, and they just have a little bit of a bump there on their AC joint, and it's not a problem. Problem is when you have a disruption here, and then you have a disruption here, okay? When that happens, you have nothing really stabilizing the clavicle. So this bone wants to go up, this bone staying in place, so now it becomes unstable. And this is where you're getting into the grade 3 to 4 type of injuries. It can vary just depending on how injured these corococlavicular ligaments are. So grade 3 AC joint separations are always they're considered a gray area type of separation, just because There's some schools of thought that think that they need to be surgically fixed. There are other schools of thought that say that they need to be fixed with a sling and conservative measures. I think it all depends on the patient, the outcome, the expectations, and their deformity and instability. If it is a very mild grade 3, where it's not very unstable, and let's say the patient's not a high impact, high contact kind of player or are interested in getting in those kind of sports, a lot of times you can treat these in slings, ice, modification activities, etc. But occasionally you do have those patients that want to get a quick return to activity, that play high contact or full contact sports, and they're concerned about their long-term career regarding this shoulder. If that's the case, you can fix these, and you can fix these by reconstructing these ligaments here and basically attaching them to that bone there that we talked about here, the coracoid. And what that entails is placing some sutures or an allograft, which is a cadaver graft, through here and actually fixating it to this bone and fixating it to this bone. And what that does is that pulls this clavicle back down, gets it back down to a normal level with the acromion, and then over time these ligaments heal back together and scar in. So that's basically a quick review of acromioclavicular joint injuries without going into too much detail there. So the next thing I wanted to talk about were dislocations of the shoulder. We mentioned before the ball and socket mechanism. So if you have a ball, this is the socket, looking at it from another view here up top, okay? So what happens when you have a dislocation, when you're abducted and externally rotated, this ball wants to go out that way. And when that happens, there's a little structure around it, these little triangles here, and that's called the labrum. And on MRI, these look like little black triangles here, okay? If you're looking straight at the glenoid, like that, the labrum surrounds the glenoid, like that, and you got the biceps up top. But the glenoid just basically is like an O-ring. It surrounds the glenoid. So it gives this ball and socket mechanism a bumper. So it protects the shoulder from dislocating frontward or backward. Gives it a little bit more support. So when you have a dislocation of the shoulder, what happens is the bone's still intact there, but this little triangle is now detached, okay? So looking at it on that view is looking at it from the top down. Looking at it from this view is looking at it straight out to the side here. And so if we wanted to see that same disruption, many times it occurs down here, like I mentioned, at the anterior-inferior aspect of the glenoid. You'll see a defect like that, where it's detached. So this labrum is detached. So it slides out, it's unstable. So now the ball and socket the ball completely dislocates, like the golf ball, golf tee analogy that I mentioned before. So what do we do in that case? Well, a lot of times, if they're young and they're active and they play contact sports, their risk of dislocation, recurrent dislocation, is high. So if they want to continue playing contact sports, then typically, to minimize risk of dislocation, prevent long-term arthritis, we recommend usually fixing this arthroscopically through a scope, a couple poke holes in the shoulder, going in there with the camera, finding this disruption in this tear. Basically what we would do is we would freshen up these areas here, which would create a little bleeding bone surface there, a little bed to put the repair on, and come through with little absorbable anchors that are made from the bone type material. And these are small little punch anchors like that, and they got little suture loops through them. And so the little anchors they loop around this labrum, and they get punched into the bone here. They loop around the labrum here, and they get punched in the bone here. Loop around here, they get punched in the bone there. Loop around here and get punched in the bone there. So that actually pulls that bumper back to the bone. So if you look at it on this view, there's a loop around here, and then there's a little, a little punch or anchor there, and that pulls that little triangle-looking bumper back down to the bone, so it heals, and that basically repairs that complex. So now you no longer have that little defect, so the ball no longer dislocates. So that's actually a very successful surgery for these type of patients. Patients do very well with this type of surgery, particularly if this is an acute injury. It's meaning that it just happened and we're getting to it early. They have great healing prognosis, and they do return to sports. Now, that being said, what happens if you ignore it? Well, if you ignore it, what's going to happen is that over time, this ball and this socket is going to completely dislocate, or the ball is going to dislocate multiple times. Well, over many years, as that ball continues to dislocate outside of the socket, it will wear away certain portions of the socket and certain portions of the ball. So you can get what's called a chronic Hill-Sachs deformity here. That's that indention in the head that we mentioned before. In addition to that, you can actually get wearing away of the bone on the cup portion of the glenoid here. And so this glenoid that used to be a nice concave structure like that now gets worn down to a flat surface because of the multiple dislocations. And so what at one time were few and I guess a few dislocations every now and then now become a recurrent chronic problem, and the dislocations occur as easily as like in their sleep. The patient will notice it in their sleep, or when they change positions in their sleep, they'll have a dislocation. So that becomes a big issue. So looking at it from the other perspective here, back to drawing the picture of the glenoid. Again, it's usually like an oval shape, but what happens is that you lose a portion of this like that. So what used to be bone here is now gone, because of multiple dislocations, and now that ball and socket is going to keep on dislocating over and over and over again because it no longer has its buttress or support there to keep it in joint. So if that's the case, what we do is the key with that is, number one, to fill in this defect here, the Hill-Sachs, so it no longer gets stuck when it dislocates. Fill that in. There's a number of ways of doing that. You can use bone graft, you can use a cadaver graft. There's even newer ways using metal implants, such as the one you're seeing here, that actually fills in that defect and gives it a circumferential surface, so it no longer gets caught up after it dislocates. But at the same time, that's only taking care of half the problem, because you still have this bony defect here. And once you're missing bone there, you're going to have to do something to replace it. So oftentimes we can use bone graft to do that, and that can come from the hip occasionally, the iliac crest. We actually take a bone graft and actually plug it into that site, and we fix it with screws. Or the most common thing that's being done nowadays is taking the coracoid. Okay, and we mentioned this before. This is the coracoid here. It looks like a finger almost coming off this clavicle. And it's right above, actually I drew that wrong, it's right above this glenoid here. It comes all the way up here like that. So it kind of hurts down like that. So it's coming off of the bone. And that's just another picture of it there, just a little bit bigger. And what we do is we make a cut right here at the base of that bone and it's a nice rounded bone, a bone block that we can use as grafts. So we make a cut right through here, take that piece of bone, and now granted that bone is attached to the conjoint tendon, so there's a tendon down here too, okay? And that actually helps also stabilize the shoulder as well when we move this over. But when we take that bone, we swing it over, and this is just different planes here, but we swing it over and fix it to the glenoid, and we fixate it with screws that hold it into place. Okay, so this is it from the, this is looking at it from up top, looking down. So we're looking down here, so you erase that. It's probably confusing people, because that's from looking at it from a different plane. But if we're looking at it from up top, looking down, this is what that bone block looks like, and it's got a couple screws there going into bone and fixating that bone to the glenoid, giving it now a buttress so the ball does not dislocate out of joint. So that is called a ladder-jig, and that is done as well, and it's actually fairly common nowadays as a very good procedure for this particular problem, because it gives you a very solid type of fixation, a very solid, stable shoulder after fixation. So that being said, as far as the recovery on these type of procedures, usually with any kind of tendinous procedure like or labral procedure like the glenohumeral instability, with a labral repair, usually we do 4 to 6 weeks in a sling depending on the severity of the labral tear. We start passive range of motion immediately after that, followed by active range of motion, or excuse me, active assisted motion, then active motion. You don't start strengthening until about 3 months out. And most patients are returning to contact sports around 6 months out after surgery. Occasionally sooner, but not very, very often. Most of the time it's 6 months. As far as like the ladder-jig, because it's a bony fixation procedure and not necessarily a tendon or labrum to bone procedure, they tend to heal up faster with the ladder-jig procedure. So sometimes those patients are returning to sports as soon as sometimes 3 to 4 months once you actually see some good bony healing on x-ray. So a lot of that depends on x-ray and also depends on the patient's symptoms. But we are getting those patients strengthening and moving a little bit earlier than the labral repairs. So in a nutshell, that goes over acromioclavicular joint separations, glenohumeral joint instability, as well as chronic glenohumeral joint instability and dislocation. So hopefully that gives you a little bit of background on what a dislocation is or separation. Just remember, acromioclavicular joint separations are different from glenohumeral joint separations. One is the shoulder, which is the glenohumeral joint. One is the acromioclavicular joint, which is the bones on top of the shoulder. If you have any other further questions, please go to the website at www.orthopedicsportsdoctor.com or www.jmichaelbennett.com. Or if you'd like to have an evaluation, call the office at 281-633-8600. And be sure to keep your eyes and ears open for the next whiteboard series. We'll be talking about some knees and shoulders, and I hope you enjoy this informative session. Thank you.